Good evening, everyone, and welcome to today's wonderful evening with Dr. Murali Bharadwaz. I'm your classmate, roommate, benchmate, tablemate. Every day holding your hand and leading you to the path of success. Yatra Yogeshwarah Krishno Tatra Pardho Dhanurdharah Tatra Sri Vijayodbhutihi, where the archer called Arjuna and the chariot called Krishna go to the battlefield, only comes the success. So every day we take opportunity to meet and take a full-scale grand test for the NEETPG 2024 with image-based questions, clinical vignette-based questions, straight liners. So let us take every opportunity to do the vision. 50 full-scale grand tests before the June 2024. You must be very confident to face the examiner head on with all the mastery in the high-yield facts and the high-yield topics. So, shuru kare? Let's start. So, doctor, can the online students can punch whether the voice is loud and clear for all of you? Yes. Ravinder Singh and many more who are all online? Good. Right. So let's start with the first question. A 60-year-old woman presents to the emergency after falling on her outstretched hand. She complains of pain, deformity in her hand. X-ray is being performed. So this is the X-ray. So what do you see here, doctor? You see the fracture. So this is an example of Colles fracture. So typically, the Colles fracture is the one which you see towards the end of the radius is what you need to basically remember. Outstretched hand is a very important point that points this towards the Colles. A 55-year-old woman undergoes abdominal imaging as a part of her health checkup. The radiologist notes several findings. So what do you see here? A cyst in the kidney. So what type of cyst is this? There is only a single cyst. That's the reason it is an example of a simple renal cyst. So even if simple renal cyst is there, this is a very everyday, day in and day out clinical scenario when you are a consultant tomorrow. If there is a good amount of functioning renal cortex, whenever you find this much a big cyst, don't get tempted to do the resection. You need to do the eGFR, that is, how is the effective glomerular filtration rate. If it is adequate to maintain the renal function, you need not do anything. Now, one of the very important question, how do you distinguish a simple renal cyst from a neoplasm? Because of the fluid density, thin wall, low fluid attenuation on the CT imaging, and discrete round borders on CT imaging. So these are the things. But the only complication of the simple renal cyst is hemorrhage. But many people remain asymptomatic throughout their lives with completely asymptomatic renal cysts is what you need to remember. A 45-year-old patient with hypertension, hematuria, family history of renal failure, abdominal imaging was performed. And what do you see in the abdominal imaging, doctor? You see multiple cysts. What is the age group of the patient? 45 years. So it's a classical case of autosomal dominant polycystic kidney disease is what you need to remember. hematuria, less commonly proteinuria, and often hypertension. And because renal tubular function get affected in polycystic kidney, it leads to development of polyuria is what you need to remember. So there are mutations in PKD1 or PKD2 genes, and they regulate the intracellular calcium in ADPKD. Where is the fundamental problem? The PKD1, PKD2, ADPKD, intracellular calcium regulating polycystin proteins are controlled. There is a bilateral renal enlargement, and it is autosomal dominant. That's the reason you don't find the cyst at birth, is what you need to remember. There's a chance of renal failure by the time they reach their middle age or late childhood. Cysts also affect the liver, pancreas, and also the spleen. And also they have intracranial berry aneurysms is what you need to remember. So that is the story of the polycystic kidney disease. So doctor, every day we meet, we prepare together, and I'll send you, if you want, the PDF for you to do the practice. All our 200 questions are based on the analysis of the PYQs, but these are all the original questions that have been created, and we are in the continuous process of guessing what the examiner wants and ultimately catering that. Okay, so learnograph.com, this is the place where you can go. You can pay 500 rupees and download the PDF, and 50 granters, 200 questions PDFs, each 500 into 50 is 25,000. But if you take it as a package, you get only for 10,000 rupees. So today only take the opportunity, or otherwise you can taste individual mock tests directly downloading the PDF from learnograph.com. So doctor, but very important, practice. The real examiner, how he thinks while framing the questions and gives in the exam hall. You need to get that practice, which is very important. Now, doctor, the next question. A prenatal ultrasound. So what does it reveal? Abnormal renal development in the fetus. Multiple renal cysts like this are there. There is asymmetry in the kidney size. One kidney large, one kidney small. And histopathology is also being given to you. So what is the likelihood? Prenatal, right in the birth, it's happening. So it is autosomal recessive polycystic kidney disease. It is more common typically, basically, it has larger cysts, and Meckel-Gruber syndrome is the one associated with autosomal recessive polycystic kidney disease. The moment the kidney in the fetus is not producing urine, there is a development of oligohydramnios and all the related complications. It can be unilateral or can be bilateral, it can be asymmetrical, is what you need to remember. Always ARPKD is associated with ureteropelvic obstruction and ureteral agenesis is what you need to remember. Now, doctor, during a routine health checkup, radiological imaging reveals changes in the kidneys in a middle-aged individual. So this is the typical gross pathological appearance that is being given to you. So what do you see here? Non-progressive dilatation of the collecting ducts and tubules in the renal papillae. So it is an example of medullary sponge kidney. And the medullary sponge kidney can be associated with Marfan syndrome, Ehlers-Danlos, Caroli's disease in the liver. So what is Caroli? Caroli is the bile duct agenesis in the liver is called Caroli. So Marfan, Ehlers-Danlos, Caroli, anything can be associated with the medullary sponge disease. 1 to 7 mm cysts in the medulla because of the dilatation of the distal collecting ducts in tubules. Typically, it is non-progressive and affects the renal papillae, medullary sponge kidney disease. And the renal function remains normal in many cases because there is a preservation of the cortex. And about 20% of the patients of medullary sponge kidney disease develop renal calculi. And the calculi will lead to obstruction, pyelonephritis, hematuria is what you have to remember. Now, a 45-year-old presents to the clinic with occasional palpitations. The patient is in no distress. ECG was being taken. So what do you see in this ECG? Basically, it is a first-degree AV block. What is the meaning of first-degree AV block? First-degree AV block means prolongation of the PR interval. Prolongation of the PR interval. P is there, QRS is there, T is there, but the PR interval prolongation alone is called first-degree AV block is what you need to remember. How much prolongation? You need to know. If it is prolonged over 200 milliseconds on ECG, you call it as first-degree AV block is what you need to remember. Now, a 70-year-old with episodes of giddiness and fatigue, ECG is being done. So what is the diagnosis in this given case? So fundamentally, between one QRS complex, another QRS complex, how many big boxes are there? 1, 2, 3, 4, 5, 6. So 300 divided by 6 is equal to 50 is the heart rate. There is P, there is QRS. There is P, there is QRS. So that is the reason this is a case of fundamentally sinus bradycardia, sinus node arrest, and there is a development of junctional escape rhythm. So typically, whenever there is a sinus bradycardia, the pacemaker is releasing the impulses very slowly. Then the AV node itself will take over the impulse, which is called the junctional tachycardia, junctional rhythm, basically. So sinus bradycardia with sinus node arrest and junctional escape rhythm is the diagnosis in this ECG. So the next question. A 54-year-old patient with history of hypertension presents complaining of palpitations. ECG is being performed. So what do you see in this ECG? In this ECG, you can see some of the P waves are inverted. Can you see? This is an inverted P wave, inverted P wave, inverted P wave. Whenever the P wave is not upright but inverted in, then you basically call it as ectopic atrial rhythm. Normal P wave should be upright, but the moment P wave is inverted, that means somewhere in the atria, ectopically it is being produced is what you need to remember. So I leave all the literature. That is, what are the high yield points that you need to remember? And the question, everything is being provided in the PDF. 200 questions, full scale grant test covering all the 19 subjects is being provided. So today only go to learnograph.com. So there we host every day the full scale grant test, and there will be a discussion. Of course, discussion is free on the YouTube. Please do join every day, but take a practice of the questions, and that is how you will lose the fear of the actual entrance exam when you go for the NEETPG. Some of my students at a point of time, only attended the full-scale grand tests and discussion regularly in the last 60 days and that back to the top ranks. So that is Dr. Murali Bharadwaz full-scale grand test. We carefully analyze the past 10 years of question papers. We reverse engineer the story. We know what AIMS asks, what INICT asks, what PGI asks, what is there in the mind of the NEETPG examiner, what are the changing trends in the pattern of exam. And based on that, we will do a mock test creation with the 30 to 40 image-based questions, clinical case minute-based questions, and very high-yield topics. Examiner is waiting to test in the real exam. So today only go to learnograph.com and we upload this 200 marks PDF into the learnograph.com. Take opportunity to buy. Every mock test will cost you around $500, but it is worth going through because there is 100% sure shot strike rate in the tomorrow's NEETPG from Dr. Murali Bharadwaz mock test series. Now, doctor, let's go to the next question. A 63-year-old patient with known history of coronary artery disease presents with lightheadedness lasting for around 5 minutes. Around 5 minutes. So, no previous cardiac conditions, hypertension was only there, ECG is being performed. So this is what was ectopic atrial rhythm, just now we discussed. Now let's go to the next question. A 63-year-old with coronary artery disease, a very important clue. Coronary artery disease presents to the emergency with lightheadedness. Lasting more than 5 minutes, BP is 110/70, ECG is being done. So what do you see here? We see broad complex tachycardia. First of all, there is tachycardia. Between one QRS, another QRS, hardly 2 large boxes, so almost 150, 160 is the rate. Then the QRS complexes are broad. Unless proven otherwise, all broad complex tachycardias are ventricular tachycardias, all NCTs. Narrow complex tachycardias are SVTs, is what you need to remember. So once more, I leave the literature in the PDF. Today only go to learnograph.com and download. Wide QRS complexes with uniform shape across the ECG means there's a single ectopic focus within the ventricle, which is leading to this typical monomorphic sustained VT is what you need to remember. Electron microscopy has been done from a patient presenting with proteinuria, hematuria. There is a complement-mediated renal pathology. Now the question is, what is that? It is called dense deposit disease, where you can see electron dense deposits are what you are seeing in the basement membrane appearing in a ring-like fashion. So it is the alternate complement pathway which is activated, leading to low serum C3 levels, while C1 and C4 remain normal. They have a circulating C3 nephritogenic factor and membranoproliferative glomerulonephritis. Typically is the presentation of dense deposit disease is what you need to remember. So now, during a routine checkup, abdominal enlargement is palpated in a neonate. So this is the typical appearance, prompting investigation. Now, there's a focal hemorrhage in the right adrenal gland, which is displacing the liver to the left. So, what is it most likely? It is an adrenal neuroblastoma. So, typically it presents like irregular tan mass with areas of hemorrhage leading to displacement of the other organs. You have the liver, but the liver is being thrown and pushed aside. That is the nature of the neuroblastoma, unlike the Wilms tumor, is what you need to remember. So it is the MYC gene amplification is what you observe. And ALK germline mutations is what you see in neuroblastoma is what you have to remember. Now, a CT scan of the abdomen of a patient who has fatigue, weight loss, hypertension, enlargement of both the adrenal glands, and he has history of inadequately treated TB. So what is this mostly likely to be? So hypoadrenalism. What is the most common cause of hypoadrenalism? Adrenal dysfunction, adrenal hypofunction. In the West, it is Edison, where there is an autoimmune destruction of adrenal. But हम इस देश के वासी हैं जिस देश में टीबी बहती है. In India, it is the tuberculosis which lead to development of the adrenal destruction leading to hypoadrenalism is what you need to remember. A 28-year-old patient consults for a dermatological evaluation because there is a lesion on the hand. It is dark to medium brown with sharp, well-defined border and smooth texture. So now the question comes, doctor, what is this lesion? It is a congenital nevus. They're present from birth, often dark to medium, sharp borders. They can remain unchanged but can extend into the deeper dermis is what you need to remember. Now, doctor, a histopathology slide of the skin lesion. Fontana Mason's silver stain. There is a fine black dusting of the melanin pigment within this neoplasm. You can see all this. What type of cancer is this which it is associated? Fontana Mason stain highlights the melanin pigment indicative of malignant melanoma. CDK N2A, which is a cyclin-dependent kinase inhibitor, is seen in both familial and sporadic cases of malignant melanoma. BRAF mutations are found in melanoma. NRAS is another gene mutated in melanoma. TURT, activating mutations of the TURT gene related to the telomerase activation, is found in 70% of melanomas. And 1/6 of melanomas are autosomal dominant inheritance is what you need to remember. So now, doctor, 70-year-old patient presents with multiple rough surfaced coin-like plaques on the skin of the face, neck, and upper trunk. And they are slowly enlarged over a period of time. They are mostly brown. So what is this? This is seborrheic keratosis. It's a very common benign skin lesion that appears warty coin-like plaques on the face and neck and upper trunk, particularly in the elderly individuals, is what you have to remember. But the question is seborrheic keratosis indicative of any malignancy? No, sir. It is not indicative of malignancy. But if the seborrheic keratosis suddenly come in multiple numbers, it's called sign of lesser Threlot. Lesser Threlot. That is Suddenly, multiple, as such, small dung is being hit on the person. Multiple seborrheic keratosis suddenly developing is called the sign of lesser Tralat is what you need to remember. 74043. Yeah. So red, yellow, green says, sir, I used to watch your YouTube videos as I could not afford the costly subscription of other companies. They helped me a lot. Now I am a senior resident in my dream branch. Wonderful, doctor. Ideally, knowledge should be free. You are doctors, we are doctors. Where is the point? But the question is, you need to end up in paying the people the bills, right? So that's the only reason that we need to look for the money. So I never looked coaching and teaching. I did it out of passion throughout my life. And today, in the hospital where I practice, most of my students, they were all once like you, preparing for the NEETPG with a lot of uncertainty in their heart. How we are going to get the seat. So today they're all top consultants. Some of them did not take any coaching except following my YouTube videos and live discussions. So thank you once more for acknowledging that you got a top rank in your dream specialty. I'm truly humble, doctor. Now, but every day we should meet at least 1 hour and prepare together. And that is the secret of becoming the top ranker in the tomorrow's NEETPG, doctor. So now let's take up the next question. A patient who is 55-year-old male with significant sun exposure history. Now there is a symmetrical dome-shaped nodule. Dome-shaped nodule. So how do you like to call this dome-shaped nodule, doctor? How do you like to classify this as? So this is arising in the pilosebaceous glands. This is an example of keratocanthoma. There's a rapid increase in size over weeks to months because of its aggressive behavior, but it will stabilize and even regress within a year, only leaving a scar. So that's what you need to basically remember. But main worry is what? Squamous cell carcinomas versus the keratocanthomas. You need to know how to differentiate. A 40-year-old male presents with a well-demarcated lesion, as what you can see. A well-demarcated lesion. Erythematous, slightly scaly plot. They are present for several years, but now becoming numerous. They have started to become nodular, ulcerate. Based on their appearance and progression, what do you like to consider? It is mycosis fungoides. Especially psoriasis, eczema, they all look like that, and it will progress into generalized lymphoma. It can lead to Sézary syndrome, is what you need to remember. So it is the malignant T cells. It can lead to erythroderma, cerebriform nucleus containing cells. These are all the features about Sézary. A child with red-brown maculopapular eruption on the trunk. The eruptions have grouped and some solitary pruritic lesions. Upon rubbing the lesion, they exhibit edema and erythema. That's called Darier's sign. So what is this called? It's called urticaria pigmentosa, which is mastocytosis. Barrier sign is very, very distinctive, especially to distinguish it from atopic dermatitis, simple urticaria, or psoriasis and mastocytosis. It is the barrier sign which is important in urticaria pigmentosa. Now, a 54-year-old patient presents with flaccid bullae on the face. Some of them have ruptured. They left a shallow erosion with dried serum and crust. Patient has oral mucosal ulcerative lesions as well. So what is it most likely to be? It is pemphigus vulgaris. So bullae often rupture, resulting in shallow erosions that can leave dried serum, that are covered with dried serum and crust. Oral mucosal ulcerative lesions can proceed. Pemphigus vulgaris versus bullous pemphigoid. One of the favorite questions of the examiner. Today only, you need to go back. Learnograph.com, we created mind maps based rapid summary and revision of 50,000 high-yield facts in the format of 19 PDFs covering 19 subjects. Today only you would pay and download. During a routine pediatric examination, what is this child is having, doctor, in the iris? It is keyhole-like lesion, which is classically of iris coloboma. It is because the incomplete closure of the embryonic fissure during the eye development. During a pediatric ophthalmic examination, there is a generalized corneal haze. There is a developmental delay. Abnormal facial features. In addition to this, what is the likelihood? It is Hurler syndrome. Hurler has a opacity of the cornea. Hunter has a clear cornea. That is the differentiation between the two. Infant presents with noticeable bulging of the eyes. On examination, both eyes show forward protrusion of the cornea and underlying sclera, giving a biconvex appearance. It is classical of bilateral anterior staphyloma, which is a severe form of corneal ectasia, is what you have to remember. Now, a child presents with a vesicular lesion on the eyelids. Some of them have crusted. These lesions are localized. They are not crossing the dermatomes. So what is the most likely possibility? This is a herpes simplex blepharitis, where vesicular lesions are affecting the eyelids, which can crust whenever they are healing, which is caused by the herpes simplex virus, is what you have to remember. A 34-year-old presents with eye discomfort, fluorescent staining showing a branching corneal ulcer with terminal bulbs characteristic of dendritic ulcer. So which is caused by herpes simplex keratitis, which lead to a typical dendritic ulcer, is what you have to remember. An infant presents with a notable eye condition, large irregular corneal ulcer with a white raised leading edge is being observed, and there is a eye redness and discharge. So it is a herpes simplex geographic corneal ulcer, is what you are able to see in this given clinical scenario. A patient is having high fever, cough and shortness of breath. A chest X-ray is being done. High fever, cough and shortness of breath. What is your diagnosis? It is Legionnaires. So it requires appropriate antibiotic therapy. Why not pneumococcal pneumonia? It will be a lobar consolidation. Why not TB? TB typically involves upper lobes with fibrocavitary lesions. Then why not pulmonary embolism? It will lead to chest pain and dyspnea, but not with fever. So that is how this is Legionnaire's disease. The patient comes for follow-up after undergoing a biliary obstruction procedure. So what are you seeing, doctor? You are seeing gas in the biliary tree. What is the likely possibility? So it is biliary enteric anastomosis can develop because of the procedure done for the biliary obstruction between the stomach and bile duct. There can be development of anastomosis, which can lead to the development of the gas in biliary tree, which is called pneumobilia, is what you need to remember. A 34-year-old patient, has a bulge in the right groin that becomes more prominent when standing or coughing, and a CT is being done. So what do you see in the CT, doctor? There is a hernial sac which is situated medial to the inferior epigastric vessels on the right side. Medial to the inferior epigastric vessels. And the bowel, typically the bowel loops are present within the hernial sac. That's the reason it is direct inguinal hernia is what you need to remember. The patient is having a history of weight loss, fever, night sweats, undergone abdominal X-ray. So past history of TB makes more likely to be hepatobiliary TB, hepatobiliary tuberculosis. So whenever TB is in the options, TB is the answer. Why not cholelithiasis? It is as a single stone, well defined. Hepatocellular carcinoma will show mass, but not calcifications. If it is a calcific pancreatitis chronically, it will not show in the liver's location, but it will show typically along the pancreas distribution only. You will find in chronic pancreatitis the presence of calcifications. A 34-year-old presents with flank pain, hematuria, history of renal tubular acidosis. X-ray is being found. So what do you see in the X-ray, doctor? You are able to see multiple renal calculi, right? Multiple renal calculi. Nephrocalcinosis is also there. So which is typical of renal tubular acidosis which the patient is having. The patient presents with symptoms of oral thrush, white patches in oral mucosa. So what do you see here? Typically oval budding yeast cells which are irregularly stained with pseudohyphal filaments which are characteristic of Candida species is what you need to remember. So why not Streptococcus mutans? It leads to dental caries, not oral thrush. Why not herpes simplex? Because it presents with vesicles, ulcers, not white patches. Now, doctor, that is the story of the image-based questions in today's mock test. So Arif Saudagar is asking very good question. Sir, please explain how to differentiate between ADPKD and ARPKD. See, ADPKD, all autosomal conditions have a variable penetrance and variable expressivity. And there's a phenomenon of anticipation, and typically ADPKD occur by the time person reaches the middle age, whereas ARPKD typically affects the pediatric age group. Further, ADPKD presents more with hypertension, renal tubular dysfunction, dyslipidemia, renal failure, etc., etc. So today only go to learnograph.com where we upload every mock test, 200 mind maps along with 200 questions, 300 pages PDF is made available. If you didn't take the 50 mock test package, which will cost you around 10,000 bucks, you can individually download the PDFs and You get it for about 500 bucks and can do the revision of all the high yield facts. Right, doctor? So, but do practice. Every day come to this YouTube live session and attend the live discussion and charge your preparation for the tomorrow's NEETPG. So, doctor, the next question. Child has difficulty in swallowing. A vascular ring is noted on imaging. Compression of the esophagus. Which embryological anomaly most likely responsible? So you need to know that it is the abnormal right subclavian artery. Right? So it is also called Lusorian artery, which is a vascular ring that compresses the esophagus leading to dysphagia. Lusoria is what you need to remember. So the left subclavian arises from the left 7th cervical intersegmental artery. And double aortic arch results whenever the right dorsal aorta persists distal to the right 7th cervical intersegmental artery. And fifth lumbar intersegmental arteries are the ones which form the common iliac arteries. So the embryology, you need to be very sure, doctor. So aortic arches, first arch, it largely regresses, forming inferior alveolar artery, which is the branch of maxillary artery. Second arch, it largely regresses, forming stapedial artery. Third arch forms carotid, common carotid and proximal internal carotid. Fourth arch, left forms arch of aorta, right forms the proximal right subclavian and brachiocephalic. Fifth arch, it does not develop in human embryo. Sixth arch, it forms right and left pulmonary arteries and ductus arteriosus on the left side. Like a parrot in the tomorrow's exam. You need to get ready with all these questions, doctor. Now, the next question about a physiology lecture, students were taught that hepatic segment of the inferior vena cava is formed by the anastomosis of which embryonic veins. So you should know very well. Cardinal veins. It is the cardinal veins fusion. Hepatic segment of inferior vena cava is formed. So you should know the right common cardinal vein gives rise to SVC. Right anterior cardinal vein contributes to IVC. Right posterior cardinal vein is the lowest part, forms sacrocardinal vein. The right supracardinal vein becomes azygous. Right supracardinal, subcardinal anastomosis form the renal segment of the IVC. The right subcardinal contributes to renal segment of IVC. So you should know the IVC formation, which is the favorite question of the examiner. A physical therapist is assessing the wrist movement. The patient can move the hand towards the thumb but has difficulty moving it towards the little finger. Which muscle group might be affected? It is the ulnar deviators. So typically, the ulnar deviation suggests a weakness or injury in the ulnar deviators. What are they? Extensor carpi ulnaris and flexor carpi ulnaris. These are called ulnar deviators. Weakness will lead to the typically the ulnar deviation is what you need to understand. A nursing mother reports tenderness in her areola. There's a swelling of sebaceous glands. These swollen glands are known as what? They're typically the areolar glands, numerous sweat glands and sebaceous glands, Montgomery tubercles, swell during the pregnancy and lactation. Now, what is the main supply of the glandular tissue of the breast? Fourth intercostal nerve. So Montgomery's tubercles, what are they, doctor? They are the sebaceous glands in the areola, is what you have to remember. Now, a surgeon is discussing an abscess in the hand that is not within the digital synovial sheath, but in a space that could affect the tendon function of the carpal tunnel area. Which space is he talking? It's called space of Parona. The space of Parona is between pronator quadratus and flexor tendons extending into carpal tunnel. Any abscess here can affect the tendons that pass through the carpal tunnel. So there's a mid-palmar space related to ulnar bursa. Abscess here is called Whitlow. Space of the Parona is behind pronator quadratus and flexor tendon. It extends to the carpal tunnel. Bunnell's no man's land. What is that? Bunnell's no man's land. It is a fibrous sheath of flexor tendons from distal palmar crease to the proximal interphalangeal joint is what you need to remember. You're examining cubital fossa. Clinician can palpate the tendon of the muscle, the main artery of the upper arm, and two major nerves. Which of the following contents are correctly paid in this location? The brachial artery is between the median nerve and the biceps tendon, is what you need to know the relationship. And the radial nerve is located laterally under the cover of the brachioradialis, not medial to the brachial artery. So you should know what are the boundaries of the cubital fossa. Pronatoris, brachioradialis, and superiorly the line between the epicondyles of the humerus. The median nerve is most medial. Brachial artery is between median nerve and biceps. Biceps brachial tendon is a middle structure. And radial nerve is most lateral under the brachioradialis. It's called my best buddy is the mnemonic. Now, a student is learning about muscle physiology and is asked the process that links the electrical signal of the muscle fiber to its contraction. What is this process called? It's a simple question. Excitation, contraction, coupling, as all of you know very well. And it is the process where a muscle fiber's depolarization lead to the contraction. So the next question. When a muscle fiber contracts, sarcomere shorten, which will describe the changes in the sarcomere. So you should know the I band decreases in width. So you need to have an idea, doctor, what is A band? A band remains constant, it does not change. H band decreases in width, I band decreases in width. Now, during muscle contraction, what is I band? I band represents the light band containing only thin filaments. It decreases in width because the thin filaments will slide towards the center of the sarcomere. The A band contains the full length of the thick filaments, which do not move during contraction. So, the A band typically does not change. I band is the one which decreases in the width, is what you have to remember. Which molecular event directly causes the myosin head to initiate the power stroke during the muscle contraction? So it is the dissociation of the inorganic phosphate from the myosin head. So the power stroke is initiated whenever the PI is released from the myosin head. And this release triggers a conformational change, which allows the myosin head to pivot and pull the actin filaments towards the center of the sarcomere. And that leads to shortening, is what you need to remember. A patient undergoes a pulmonary function test that has measured the respiratory minute volume of 5.5 liters, maximum voluntary ventilation of 150. What is the patient's dyspnea index? So, percent of respiratory capacity is not used at a given respiratory minute volume. So, typically, MVV minus MV divided by MVV into 100 will give you the dyspnea index, is what you need to remember. If you apply those values, you will get the correct answer. So the respiratory minute volume is tidal volume into respiratory rate 500 ml into 12 is 6000 ml. Alveolar ventilation is tidal volume minus dead space into respiratory rate, which is 500 minus 150 into 12, which is 4.2 liters. Maximum voluntary ventilation is called maximum breathing capacity is 125 to 170 liters per minute, is what you need to remember. So in this case, 150 minus 5.5 divided by 150 into 100 is 96.7%. So that's a point. Now, doctor, let's go to the next question. Which gas has the highest diffusion coefficient in respiratory membrane, therefore expected to diffuse most readily? So you need to remember that if you look at the diffusion coefficients of the gases, oxygen is 1, carbon dioxide is 0.81, helium is 0.23, nitrogen is 0.53. So that is the reason the carbon dioxide typically has a higher diffusion coefficient in the respiratory membrane than oxygen, because CO2 is more soluble even though it has similar molecular weight, and that will allow CO2 to diffuse more readily despite a smaller diffusion gradient compared to the oxygen, is what you need to remember. So what is meant by diffusion capacity? It is the volume of the gas which is diffusing through a respiratory membrane per minute per 1 millimeter mercury of pressure gradient, is what you need to remember. Now, which component of the renal corpuscle typically senses that sodium concentration inside the glomerular filtrate and accordingly will signal the release of renin, angiotensin, and adjust the GFR? It is the macula densa. They are specialized epithelial cells in the distal convoluted tubule. They sense the changes in the sodium chloride and signal the tubuloglomerular feedback, is what you have to remember. So every NEETPG doctor, they will invariably ask you questions on the renal physiology. You need to be very sure. Which hormone is released in response to low BP, resulting in secretion of aldosterone, doctor? It is the renin, is what you need to remember. And where is renin produced? Renin is released by the juxtaglomerular cells when there is a fall in the BP. It acts on angiotensinogen. Now, angiotensinogen produced by the liver, cleaved by the renin to angiotensin 1, angiotensin 1 converted to angiotensin 2 by the ACE, mainly in the lung capillaries, is what you have to remember. Now, which enzyme is responsible for the removal of the amino group in the form of ammonia from the glutamate? It is the glutamate dehydrogenase, responsible for the oxidative deamination of the glutamate. Right? Converting it into alpha ketoglutarate and releasing the ammonia, which is used in the urea cycle for excretion. So you should know everything about the urea cycle, etc., doctor. So the removal of ammonia from amino acids forming alpha keto acids is called oxidative deamination. It is reversible, and glutamate dehydrogenase is the key enzyme And NAD plus, NADP plus are the coenzymes, and main site is the mitochondria in the liver, and that lead to the formation of the ammonia, which enters into the urea cycle, is what you need to remember. So there is oxidative and non-oxidative deamination. So in the non-oxidative deamination, it is the FMN, which is the coenzyme, whereas in oxidative deamination, it is the oxidative deamination, it is NAD plus and NADP plus. Non-oxidative occur in liver and kidney, and serine histidase, serine dehydratase, they are all the example of the enzymes involved in the non-oxidative deamination. Now, doctor, which statement describes the urea cycle significance in metabolism? Obviously, whole purpose of urea cycle is to detoxify the ammonia by converting it into urea. So what is the entry compound into the urea cycle, doctor? Ornithine. By the time cycle is over, ornithine comes in, ornithine gets created. And where is ATP consumed? When carbamyl phosphate is produced, 2 ATPs are consumed. Totally 4 ATPs are the ones. So overall reaction is ammonia plus carbon dioxide plus aspartate gives rise to urea and fumarate. So there is no net loss or gain of intermediates. Aspartate is consumed and fumarate is generated. And the whole purpose of the urea cycle is to convert the ammonia to urea for the excretion, is what you need to remember. Now, which spectrometry technique is used to determine the molecular proteins by measuring mass to charge ratio of the ionized peptides? It is the mass spectrometry. So we use Edmond degradation using Edmond's reagent, which is phenyl isothiocyanate, while doing protein analysis. And various techniques are used. And what are the types of mass spectrometry? Tandem, time of flight, quadruple, blah, blah, blah. But ultimately, you need to know what is the definition of mass spectrometry for the tomorrow's NEETPG. More than enough. With regard to the composition of the fats, triglycerides are the esters of the fatty acids with the glycerol. So what is glycerol, doctor? 1, 2. What is glycerol? 1, 2, 3. Propane triol. CCC. Right? 3 carbons is propane. Triol. 3 ols. OH, OH, OH. Once this OH is replaced by the acetyl, then it becomes triacetyl glyceride. This is the glycerol backbone. Triglyceride is the main fat, as all of you know. So what is the component which is common to both sphingolipids and glycolipids, doctor? It is the sphingosine. It forms the backbone to which the fatty acid and either phosphate in case of sphingolipids or carbohydrate in case of the glycolipids get attached. So phospholipids composition is what? Fatty acid plus alcohol. It can be glycerol or sphingosine plus phosphate. And how many types are there? Glycerophospholipids, sphingolipids. Example is sphingomyelins. Then glycolipids, fatty acid, alcohol, and carbohydrate. So what are the types in that? You have cerebrosides, which is fatty acid plus sphingosine plus simple sugar. Ganglioside is fatty acid plus sphingosine plus oligosaccharide plus oleic acid. That is what you need to nail it down. A patient presents with orange-colored tonsils, hepatomegaly, noted deficiency in HDL cholesterol. Which gene is abnormal? ABCA1. So you should know Tangier's disease. Severe deficiency of HDL cholesterol and deposition of the... Normally, what is the role of the HDL? It is a scavenger of the cholesterol. It takes away the cholesterol from the tissues. If the HDL deficiency is there, because of mutation of ABCA1 gene, then the cholesterol get deposited everywhere, even on the tonsils, which is called Tangier's disease. So where is ABCA1 gene, doctor? 9q31. Enlarged tonsils, hepatomegaly, splenomegaly, neuropathy, coronary artery disease, thrombocytopenia, MTP gene defect, LCAT deficiency, corneal opacification, anemia, fish eye disease, it is called. LCAT deficiency is called fish eye disease, is what you need to remember. So now, doctor, a 65-year-old history of smoking with confusion, seizures, hyponatremia, urine osmolality higher than serum osmolality. What is the most likely diagnosis? CR. What is syndrome of inappropriate ADH secretion? When ADH is produced inappropriately, then what will happen? ADH, antidiuretic hormone, is produced. There is no diuresis. When there is no diuresis, all the water in the tubules is reabsorbed back into plasma. When all the water is in plasma, there is an increased plasma volume that will make the heart to stretch. Atria produce atrial natriuretic peptide. Atrial natriuretic peptide comes to the kidney and cause natriuresis, and there is a loss of sodium into urine. That is the reason what will happen. Urine osmolarity becomes high, serum osmolarity becomes low, urinary sodium becomes high, more than 20. So that is the definition of SIADH. Now, doctor, a 40-year-old history of depression, expressing feelings of hopelessness, that he would not mind if he did not wake up tomorrow. What is the most appropriate next step to manage this given case? So you should know. Ask the patient, a depressed patient, about what is his plan for suicide. Only don't ask, what is your plan to the NEETPG preparing aspirant? Only plan is attending 50 full-scale grant tests in the next 60 days with Dr. Murali Bharadwaz. That's the only plan that you need to have. So go to learnograph.com, download the mock test PDF every day, and then solve the paper. Evening, come for the discussion. Right, doc? So prescribe, ask the patient any specific plan, because that is the most urgent thing that you need to attend. So, doctor, with this, we come to the end for the today's afternoon. So tomorrow, once my morning OP is over, pre-lunch, I'll try to scratch some time once more to sit with you to discuss these remaining questions in the paper. So thank you all for patient attending, and every day milenge, every day padenge, सात पढ़ के 50 full scale grant tests solve करके 10,000 questions, ditto will come in the tomorrow's NEETPG, doctor. And one day आपका number आएगा, आप बोलेगा, अरे sir, every question I am remembering you. याद आना है मुरली भरद्वाज आपको exam hall में. Every question when you are answering, you need to say, wow, that day we discussed Tangia. That day we discussed about herpes simplex, dendritic ulcer, geographic ulcer. Oh, that day we discussed the CCG in the mock test. वो बोलना है. 100% strike rate रहेगा. Be part of the full scale grant test series and discussion with Dr. Murali Bharadwaz every day. Good night.